This conference will now be recorded.
So today we are going to discuss this July 2020 talk. I have done this two together because the syphilis talk was a small talk, and another thing is laparoscopy in pregnancy. It was a tips and tricks. Usually all tips and tricks, the articles in the talks, they are not all are required, but specific to something. If it is regarding like specific to some surgery, then better to read it. Okay. So because this is a laparoscopy in pregnancy, they have given some very good points. So better to do that one. So I have included that also. So coming to the first syphilis talk. So syphilis is a bacterial sexually transmitted infection. The causative organism is Treponema pallidum. It is the most common congenital infection, bacterial infection worldwide. Okay. Incidence has risen in the UK since 2013. Almost 50% syphilis cases they are in London, and 75% they are present with men who have sex with men. Here, the co-infection with HIV is present in almost 40% of patients. Incidence of syphilis in pregnancy, it is around 1 in 700 to 1 in 7,000 women in pregnancy, and out of that, 1 in 4 these have new infection. The others, so other three, 1 in 4 they have no infection, while the other 3/4 patients they are who are screened positive. There can be the reasons for this. They can be either inadequate treatment, okay, or false positive results because of other inflammatory conditions or infections. So only 40% of patients who screen positive they require antibiotic treatment. Risk factors for syphilis: low socioeconomic status, multiparity, history of STIs, use of illicit drugs before the age of 18 years, illicit drug user by the current partner, poor engagement in antenatal care, and 3 or more sexual partners in previous 1 year. Transmission is mostly via sexual contact, 1/3. So transmission rate is, it is 1/3. So it is around 33% individuals exposed to the disease, they become infected. Extragenital source can be also there, like anal, rectal, or oral route. Transmission also occurs transplacentally during any stage of pregnancy. Remember, so syphilis can be transferred during any stage of pregnancy, and the risk of transmission, it depends upon the stage of maternal syphilis and duration of fetal exposure. Stages of syphilis. Now the syphilis is known as great imitator. Why? Because it has a very vague presentation. Okay, non-specific symptoms will be there, very vague presentation will be there, so it is called as great imitator. The syphilis is divided into early syphilis and late syphilis. Early stage is again divided into primary and secondary syphilis. So primary and secondary, once the patient goes through this primary and secondary syphilis, then the patient enters into the period of quiescence, which is known as latent syphilis. Okay, so what do you mean by this latent syphilis? Here the patient will be asymptomatic, but the patient remains infectious, and that test will be positive in this latent syphilis. So early latent syphilis, it's infection that has occurred within past year, while late latent, it is infection which is occurred more than 1 year back. After 20 years of primary and secondary syphilis, the patient may present with tertiary syphilis. These are the stigmata of syphilis, also known as late syphilis, and it is usually complicated by neurological, gametus, and cardiovascular manifestations. So this is known as tertiary or late syphilis. So coming to the primary syphilis, this is the most usually asked question in your exam. Incubation period for syphilis, it is 9 to 90 days. The primary manifestation of primary syphilis is a chancre. So chancre is a endless indurated ulcer which is non-purulent. Usually single in genital area, but outside genital area it can be multiple and painful also. So you can see here, this is the chancre. Okay, so this chancre heals spontaneously over 3 to 8 weeks. Untreated patients, so out of those, 25% will develop secondary syphilis. If they remain untreated, 25% will go to the secondary syphilis. So secondary syphilis, it occurs 4 to 10 weeks after the primary chancre. The symptoms are general malaise, flu-like symptoms like loss of appetite, lymphadenopathy. Generalized mucocutaneous rash, which will be there, which can affect mucous membrane or palms and soles. So here you can see this is the rash. So mucocutaneous rash will be there. Also perianal condylomata, that is discolored warty infectious lesion. This can be also extragenital. And other signs of secondary syphilis are meningitis, eye infection like uveitis or optic neuropathy, hepatitis, glomerulonephritis, and splenomegaly. So it is a usually wide systemic infestation. Okay. Then secondary syphilis, this usually resolves within 1 to 3 months before it enters into latent phase. But 1/4 of patients, 1/4 of patients, they develop recurrence of their secondary disease in initial part of latent stage. So first of all, primary syphilis, then secondary syphilis, then they enter into the latent phase. And if untreated, 30% patient progresses to tertiary or late syphilis, and it is associated with cardiovascular and neurological complications. Now coming to the syphilis in pregnancy. So if the woman is infected during pregnancy or becomes pregnant when she is already infected and not treated, it will be very dangerous to the baby. So what happens here? From as early as 14 weeks of gestation, spirochetes, they are transmitted. They can cross through the placenta and cause fetal infection. And the risk of transmission increases as the pregnancy progresses towards the term. Fetal loss is very common. So 30 to 40% of cases, there will be fetal demise. Okay. Fetal loss, it is caused by infection of the placenta and compromised blood flow. The fetuses which survive, out of that 1/3, they will born with congenital syphilis, signs of congenital syphilis. Now the transmission varies upon the stage of syphilis of the mother. So primary syphilis, the transmission rate is as high as 100%, while in early and late latent syphilis, the transmission rate is around 40% and 10%. So early syphilis, it will be 40%, late syphilis, it will be 10%. Now, how you are going to identify this fetal infection? If the mother is having syphilis or detected to have syphilis, how you are going to identify this fetal infection? So usually it is a placental involvement and hepatic dysfunction. So it will result in fetal growth restriction, hepatomegaly, thrombocytopenia, anemia, and ascites. Also increased risk of preterm birth, stillbirth, and neonatal death. Ultrasound features are ascites, hepatosplenomegaly, intrahepatic calcifications, and placentomegaly. And in severe cases, they will develop into distorted fetal long bones or fetal hydrops. So 6 to 10% of fetal hydrops, these are caused by congenital infections, not only syphilis, but other congenital infections also. So here you can see this is the fetal hydrops where you can see the pericardial effusion and ascites also. And then or pleural effusion. Then next thing is fetal intrahepatic calcification. You can see this. Oh, sorry. So this is fetal intrahepatic calcification. So these are the sonological features of fetal infection. Now, this is the most important thing. You usually get questions on this, how regarding the testing of the syphilis. So for laboratory testing and diagnosis, 3 methods which are commonly used. So one is direct testing method. Here you can use either direct field microscopy or PCR on the direct swab. Okay. Then serological test or blood test. So here there will be, you are going to test either antigen or antibody specific to treponemas. Okay. So it will be either enzyme amino acids or particle agglutination assays, and non-treponemal serological tests like RPR and VDRL. So these are the different types of tests. So now how exactly this test should be done? Also, this is also again routine we asked. This was a recall, I think, in February also. So false negatives, these are commonly seen in HIV positive patient. Also, false negatives are seen in latent syphilis. Okay, latent syphilis, where sometimes in undiluted serum you will get this test as negative, false negative, even if the patient is having this latent syphilis. False positive, VDRL and RPR, they are found in other treponemal infections like yaws, systemic inflammatory conditions like endocarditis, and pregnancy itself. And serological false positive, treponemal serological false positive test can be seen in other infection and inflammatory conditions like systemic lupus SLE. So what are the nice recommendations for testing for syphilis? So first you have to send 10 ml clotted blood. Okay, to obtain first full syphilis screen. So here full syphilis screen means you will going to do enzyme immunoassays and TPPA. That is Treponema pallidum particle agglutination assay. So these are the both tests. These are the most commonly used in NHS. So first test is done by enzyme immunoassay and TPPA. And also, if the primary chancre is there, you can take swab. Okay, so flock or virologist labs, these are done for PCR. Okay, these are tested for PCR and also for herpes simplex as a differential diagnosis, and also screening for other STI. If it is suspected of syphilis, you have to screen for other STIs also, like chlamydia, hepatitis B and C, and HIV. If the patient consents, it is important. If the patient gives consent, you have to test for or screen for other STIs. So this is the screening protocol. Now this is the most important part of this talk. So antenatal screening protocol. So first at booking visit, as I have already told, you have to see test for treponemal serological test. It is a treponemal serological test. It can be done by enzyme immunoassays or chemoluminescent assays or TPPA. So any one of this treponemal serological assay, one test is done. If it comes positive, then you have to confirm it by another test. If it is negative, then leave. So now if the test results are negative and suspicion of syphilis remain, repeat serology should be done at 6 and 12 weeks after the date of last sexual contact to allow for incubation period. Okay, so 6 and 12 weeks. If the test is negative and still the patient is suspicious, repeat it at 6 and 12 weeks. Now if the screen test comes positive, then you have to confirm it, because as I told you, false positives are more common with syphilis. So after one test is done, you have to confirm the test by other serological test, which is not a primary test. So if you have done enzyme immunoassay, then you will be doing TPPA. Okay, so if you have done TPPA, then you will do either TPHA or enzyme immunoassay plus again one more serology test. So total for confirmation, total you are going to do 3 tests. First, there will be one basic test, either enzyme immunoassay or TPTA. Then it is confirmed by another serological test. Then once you have confirmed that this is a syphilis, then you are going to do RPR or VDRL. Why RPR or VDRL? To see for the response, okay, to monitor the response basically. VDRL and TPRA, your RPR, you are going to do for monitor the response, and refer to gum and pediatric neonatal care, okay, for this congenital syphilis, to rule out congenital syphilis and to make a plan regarding this. Now, if the syphilis is negative and the patient is high risk, okay, so if the woman declines the test or if any risk factors are present, then you have to repeat the screening after again 3 months. So in case of high risk, so what are these high risk? One is new or multiple sexual partners, commercial sex work, main sex with men, that is sexual contact with men having sex with men, and sexual partner from the endemic countries like Africa, Southeast Asia or South America. So in that case, you are going to again repeat it after 3 months. So every 3 monthly, you will be doing this if there is a she belongs to high risk group. So this is regarding the screening protocol. Now, once the screening has come positive, then it is the management part. So management of syphilis in pregnancy, this is the very easy thing to remember. And another thing is, this is the most commonly asked question also. So for first and second trimester, for early disease, you are going to use benzathine penicillin 2.5 million units intramuscular single dose. And third trimester, you are going to use 2 doses. Okay, 2 doses for, that means day 1 and day 8. Okay, day 1 and day 8, benzathine penicillin 2.4 million units intramuscularly for third trimester. And for late disease, you are going to use benzathine penicillin 2.4 million units intramuscularly weekly for 3 weeks. Okay, so for late disease, this regimen is used in all stages of pregnancy. Other treatment, this thing, so it will be a multidisciplinary team involvement with involvement of genitourinary physicians, neonatologists, and microbiologists. And the mainstay of treatment is antimicrobial therapy. As I told you, it is benzathine penicillin, counseling, partner notification, and safer sex advice. Usually treatment should be done at least 30 days before delivery. So it is the most important factor which influence the risk of congenital infection and perinatal mortality. Now these are the two things more again important. So sensitive to penicillin. The patients who are sensitive to penicillin but who can tolerate cephalosporins, you can use ceftriaxone 500 milligram intramuscularly for 10 days. 500 milligrams ceftriaxone intramuscularly daily for 10 days who are sensitive to penicillin but can tolerate cephalosporin. And the patients who are not penicillin allergic but who are unable to tolerate intramuscular regime, then it is amoxicillin plus probenecid oral 4 times a day for 14 days. Then again, it is a Jerich-Herxheimer reaction. It occurs in 45% of syphilis treatments in pregnancy. It is associated, the cause of this reaction is because of this large numbers of these organisms, spirochetes are killed, they will release excessive cytokines which initiates this acute inflammatory reaction. So symptom usually occurs within first 24 hours of antibiotics, and it includes fever, rigors and skin rash. And in pregnancy, the typical features is uterine contractions, and because of that, FHR abnormalities can be also there. This reaction is particularly common during the management of early disease. So it occurs in 50% of primary syphilis, 90% of secondary syphilis, while latent syphilis, the reaction rate is only 25%. Treatment is usually supportive, consisting of fluid, supportive care, and symptom control. Now coming to the congenital syphilis. Congenital syphilis is divided into early and late syphilis. So early syphilis, it is within first 2 years. Late syphilis after the age of 2 years. 2/3 of babies with congenital syphilis, they are asymptomatic at birth, and of these 2/3 will demonstrate the signs within first 3 to 8 weeks of life, and most they will present before 12 weeks of age. Congenital syphilis is a multisystem infection which can result in neonatal death and long-term disability. So early syphilis signs include skin rashes, meningitis, jaundice, hepatosplenomegaly, deranged liver function, also increase alkaline phosphatase. Blood test also serves anemia, monocytosis, and thrombocytopenia. X-rays demonstrate periostitis, which leads to bone deformity. Bloody cephals means syphilitic rhinitis. It is a pink-colored nasal discharge, so it is a characteristic of syphilis. Then late syphilis, late congenital syphilis, sign symptoms, usually it is a Hutchison triad. Okay, Hutchison triad it is known as. So it is a eight cranial nerve deafness, interstitial keratitis, and Hutchison teeth, that is notch incisors. Also, there will be bony deformities because of chronic inflammation. Syphilitic rhinitis, it leads to saddle nose deformity and saber shins, that is anterior bowing of mid tibia. So it is a bony deformity. So this late congenital syphilis, it will be very devastating. 1/3 to 1/4 children, they more than 2 years, they will have asymptomatic neurosyphilis, and 10% more likely, the babies, they are 10% more likely to die in the first year of life. So pregnant women, they should be advised that with appropriate treatment, they can prevent or minimize this neonatal complications. So screening and treatment of syphilis in pregnancy, it will minimize the neonatal complication and can prevent congenital infection also. So this is regarding the syphilis talk. Then coming to the next talk of this July 2020, it is operative laparoscopy in advanced pregnancy beyond 20 weeks. 0.5 to 2% of women, they require non-obstetric surgery during pregnancy. The most common indications are appendicitis, acute cholecystitis, and torsion of adnexal mass. Usually, previously, advancing pregnancy, it was considered as contraindication. They used to do the laparoscopy before 20 to 24 weeks of pregnancy. After that, it is usually contraindicated. But now there is growing evidence that it is safe in all trimester. So, what are the top tips for performing laparoscopy in advanced pregnancy? This is the basically the all TOG lies. So all this article lies in these few points. Okay. So first, that experienced surgeon and anesthetist should be involved in the surgery. Give antacid prophylaxis to minimize the risk of aspiration. Also, consider nasogastric tube insertion, same to minimize aspiration. Apply left lateral tilt to avoid aortocaval compression. Perform any changes of position very slowly. Entry technique using either Hassan or Palmer point entry. Consider the use of ultrasound to facilitate entry to avoid any injury to the uterus. Use lower pressures of 10 to 12 millimeters of mercury and auscultate the fetal heart prior and after the surgery. So this is the main precautions that you have to take during the operative laparoscopy during pregnancy. Now, what are the benefits of this laparoscopic approach? These are same to other laparoscopic surgery, that is reduced length of hospital stay, faster return to work, less post-operative pain, lower incidence of post-operative ileus, venous thromboembolism, and wound site infection. And pregnancy-specific benefits are reduced maternal hypoventilation and neonatal respiratory depression, secondary to reduced maternal opiate requirements. Risk of uterine perforation, laceration of the fetus or placenta, uterine rupture, uterine infection. And also clinicians should they maintain low threshold for conversion to laparotomy if the complication occurs. Okay, so if any complication is suspected, there should be low threshold for laparotomy. 23% of laparoscopy who has been done for acute appendicitis, these are negative. This is the one major percentage that we can ask in your questions. Okay, so suspected appendicitis, 23% laparoscopies, these are negative. Now, anesthetic concerns in late pregnancy laparoscopies. So from 16 weeks onward, there will be delayed gastric emptying, reduced lower esophageal sphincter tone, and increased pressure from gravid uterus. So all three, they increase the risk of aspiration pneumonitis. So for that, antacid prophylaxis and elective nasogastric or orogastric tube insertion should be considered, and early involvement of experienced obstetric anesthetic should be there. Now, for monitoring maternal carbon dioxide levels, you have to use end-tidal carbon dioxide levels. So, it is a safe and efficient means to monitor this carbon dioxide levels. No evidence of associated increase in teratogenicity, miscarriage, and preterm labor or intrauterine death because of this anesthesia. Okay. Then, during the procedure itself, as I previously told, left lateral tilt should be used and slow change in the position to avoid this aortocaval compression. Then for entry technique, you have to use either Palmer point entry or supraumbilical open Hassan technique. Okay. Sometimes you can use this ultrasound guided varus insertion needle or visual optical trocar systems. Okay. Then uterus should not be instrumented, but if it is required, you can use swab on stick to provide gentle manipulation of the uterus. And as I told you, to prevent aspiration, you have to use or consider nasogastric tube to decompress the stomach. Then regarding instrument, 30-degree laparoscopes, they provide better visual access. And for cautery, better to use bipolar electrocautery to avoid any stray current which can go through the fetus through amniotic fluid. Then specimen should be usually retrieved using normal retrieval bags, okay, standard retrieval bags. Then raised abdominal pressure, intra-abdominal pressure, it can cause fetal hypoxia by restricting uteroplacental blood flow. That's why the operating pressure should be used at low pressure, so less than 12 millimeters of mercury. But if the visual access is poor, then you can use up to 15 millimeters of mercury. They can be used safely. No evidence to support routine use of tocolysis, but in case of preterm, suspected preterm, you can use tocolysis along with steroids and Maxil. So these are the things they have given specifically for this Hassan entry. So Hassan entry, you have to take incision through umbilicus and take this umbilicus, okay, umbilicus stalk out and incise through this umbilicus stalk vertical incision and do the direct trocar entry. So this is the Hassan technique. And for Palmer's technique, you have to insert this Palmer's needle in the, varus needle through the Palmer's point. So these are the entry technique which are used for this alternative entry technique for late pregnancy laparoscopy. So this is regarding this laparoscopy talk. So today I think we have done 2 talks. Tomorrow we will be doing one more. I think till Wednesday I can do it. After Thursday, so from Thursday onward, I will be busy for almost 1 week. So I couldn't do for 1 week from Thursday to next Thursday. Okay. Then again we will resume. So I think we will do it till Wednesday. So we will finish this July 2020 talks by Wednesday. So thank you for attending. Tomorrow we will do with another one. Okay. Bye then.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you.